This week on the BackTable podcast.
You always have to think where you got to get to relative to the orchiectomy site, right? If it's a testicular primary, if it's a retroperitoneal primary and you're not worried about resecting the gonadals, then it's not as much of an issue. But 99% of cases that we're doing, you always have to think where you got to get to relative to the, I'm always thinking about that distance between the caudal aspect of my incision and where I need to be able to retract down to get down to that internal ring to retrieve the entirety of my spermatic cord. So it does vary a little bit. It's pretty rare for me to go in for umbilical with my incision generally, but obviously if you have in more advanced cases, let's say you got a 30 centimeter mass, well, then you're doing kind of stem to stern kind of incisions, but those are pretty rare for us these days.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. This is Aditya Bagrodia as your host this week, and it's my honor to introduce our guest today, Tim Masterson from Indiana University, and Rob Hamilton from Princess Margaret Hospital, University of Toronto. Tim, Rob, how are y'all doing today?
Doing great.
I'm doing great, Aditya. Thanks for the invitation.
Yeah, thank you.
Now, this really is an honor. You both are people that I have looked up to my whole career. The contributions to germ cell tumor management, the thoughtful approach is something I think for myself and anybody kind of interested in this disease to emulate. And so today we're going to talk about post-chemo RPLND, kind of perioperative considerations. It's so fun to pick your all's brains. I got to make sure I don't have what happened with Clinton Guggen, where we intended to talk about the operation, but literally never got to it. So, maybe just like jumping on into it, we'll minimize some of the preoperative considerations. Let's just say a post-chemo RPLND is warranted. They had metastatic disease, they received chemotherapy, and they've got residual masses greater than a centimeter. And for sure, we'll talk about adjunct surgery and all of that kind of stuff. How do you start preparing? When you're sitting down with the patient, having that conversation, let's maybe start with that. How do you start preparing the patient and yourself for what this operation may look like? Rob, you want to kick off?
Sure. And as you already alluded to, it's a very individualized thing. I think primary is a more ubiquitous, homogeneous operation often, whereas post-chemo, the variety can be quite varied depending on the patient and the mass. But I go through the images with the patient. I think a picture's worth 1,000 words, and I'm sure you guys do the same. And I show them exactly where, correlated to where on their body. And then I map out the extent of resection. Is this going to be a long day at the office or a short day at the office for them and for the family, for their expectations? I'm sure we'll get into this. We talk about rationale, why we're doing the post-chemo RPLND, what we're looking for, what we expect on the histology. And then I get into the discussion of potential complications, length of stay, and what to expect afterwards, how long till you're feeling back to yourself. So that's sort of my general outline. I'm sure we can go into detail if you like.
Yeah. I mean, a specific question, whether it's post-chemo cystectomy or post-chemo RPLND, where a non-trivial amount of the time you're going to have no viable germ cell tumor, no teratoma. I'd be curious, how do you kind of prepare the patient for these possible histopath outcomes? Tim, you want to take a stab at it?
Yeah, I mean, I think in the routine situation, you generally quote a 50% chance and a residual mass of having teratoma, about a 45% chance of having necrosis, and about a 5% chance of having viable germ cell tumor. So I think that, from a prognostic standpoint, we talk about a 95% chance that if you find either teratoma or necrosis, you have a very good prognosis long-term. So there's a very small percentage of patients that will warrant additional considerations for as far as adjuvant therapy afterwards or additional concerns for the higher chance of relapse. So, but if they have teratoma or necrosis, I generally reassure them that would be a good thing to find. And teratoma is what we're doing the operation for sure.
And I would just add on to that. I agree completely. What I remind the patients of those is we currently don't have a reliable way to distinguish between those three histologies pre-op. So yes, you prepare them for the possibility that we find necrosis, which is obviously the best of the three outcomes, but we don't know. We don't know till we get in there. And just because you found necrosis, yes, you could go back in time and say, I wish I wish we knew that pre-op and maybe you wouldn't have done the surgery. But if you're removing a 10 centimeter necrotic mass, there's been a handful of studies that have shown it's just impossible for the pathologist to cut every single micron of that tumor. And so the theory is that perhaps there is microscopic elements in there that are just not called on final path. And so I think getting a result of necrosis is, yes, it's good, but it doesn't mean you didn't absolutely have to do the operation. The operation had to be done.
Yeah, I don't think I have anything to add on top of that. It sounds very, very similar. What if a patient asks you, Doc, what if we wait 8-12 weeks? They've got let's call it a 3 centimeter mass, nothing overly offensive, like a malignant transformed tumor on their orc. What does that conversation look like?
Well, typically we will wait 4 weeks from the time of chemotherapy completion, just in general. So you allow their hemoglobin, their platelet counts, their white blood cell counts to recover. So usually we'll give them 4 weeks to do so. So it kind of depends on when their conversation's being had. I will say this is probably one scenario where we don't put a huge emphasis on a timeline. If you do their operation in 4 weeks, 6 weeks, 8 weeks, let's say it's a college student and he just wants to finish his semester and do it on, his winter break. I don't put a lot of concern on that kind of timeline. If he says, I want to do it next year, well, that's a different scenario. The chance of having progressive growing teratoma or even transformation of teratoma into a more challenging entity of somatic transformation, it's unlikely to develop in that time period. So I think a short period of time of saying there's some grace and it doesn't have to be done tomorrow is okay, but putting it off 6-12 months, I would not advocate for.
Yeah, I completely agree. And I think, you intrinsically know the guys that you're worried about and the guys that you are less worried about. And the IgCCCG risk pre-chemo has a lot to do with how worried you are post-chemo, the response of their mass. Post-chemo, so if they had a massive reduction, yes, it's over 1 centimeter, but if they've had a massive reduction, I worry less about that guy than someone who's, had a very minimal reduction and it's still sitting at 5 centimeters. And they had, as you mentioned, Aditya, they had some teratomatous or transformed elements in their primate. Those are the guys you worry more about, and you've got to get on them faster than the guy who had a massive reduction and wants to finish his school.
Yeah, and I think, if they're right at that 1 centimeter cutoff, and certainly if chemo was a little bit more involved, I think giving a little bit more time, re-imaging to see what happens isn't that offensive. And if it's cystic, if it was associated with plenty of teratoma, I think those are more straightforward cases. And I don't try to initiate like a fear-based conversation, but I'm like, there are small percentages this could grow rapidly, that this could transform. The likelihood of it happening in 8-12 weeks is pretty small, but try to meet patients where they're at, I think, more or less. So you mentioned complications, Rob, and I'd love to hear your, let's say it's a more involved mass, maybe some encasement of the aorta, the renal hyla, some of those trickier masses that are at the left periaortic, perihilar region. What does that look like?
Yeah, so I break it down into categories, and then the extent that you go into categories depends on the extent of the mass. So I always start with common things, so bleeding, chance of infection. The two I spend the most time on is ascites and loss of ejaculation. And again, that depends on how involved the mass is, if it's bilateral or unilateral. So the extent of that conversation goes based on mass. And then I get into a category I call injury to other organs. And that's where, as you alluded to, if it's up by the kidney, up by the renal vessels, I talk about possible risk of ureter, renal vessels, need for nephrectomy. I talk about injury to bowel, injury to other major vascular structures. So that's all in that category. And then, we talk about other sort of common abdominal operative post-op complications of ileus and obstruction and DVT, PE, pneumonia, those sort of things. But the biggest chunk is that ascites, loss of ejaculation, and injury to adjacent organs. That's the three biggest categories we spend most of our time discussing.
Tim?
Yeah, you talk about kind of preparation for intraoperative findings and complications. I think the biggest thing for us is just kind of looking to imaging ahead of time and trying to prepare ahead of any scheduled procedure to make sure you have all the hands on board that you need. So, if there's concern for duodenal involvement, do you have a trusted surgical oncologist if you know that there's going to be need or a high risk of vascular injury or vascular replacement that's going to be needed because of encasement of the aorta or distortion of the aorta, then you're making sure you have a vascular colleague on board. Or if there's retrocrural disease, having we use a thoracic person to help us mobilize, above the stomach and liver to get the high retrocrural stuff. So just making sure more than anything, preoperative planning. So if there are issues from a complication standpoint or a technical challenge that requires adjacent structure removal or manipulation to have the right hands on board. I think that you never want to find an intraoperative consult intraoperatively. You want to have everybody lined up ahead of time, and that makes it safer for the patient, and it gives you the reassurance that you have everybody you need if you run into this situation. So, and I think sharing that information with the patient and making sure they understand that. Otherwise, I think exactly what Rob talked about is almost systematically the exact same thing we talk about as well.
Do you all talk about unresectability or death?
No, I cannot say that I specifically talk about on-table death. Knock on wood, I haven't had one, so perhaps that's why I haven't brought it up. Unresectability, I'm also trying to think. I don't know that I've aborted on one, to be honest. I think there's some time when it's incredibly fibrotic around a major vessel, and you make the decision that you think that the yield in resecting what you are almost certain is just fibrotic plaque necessitating a major vascular reconstruction is not worth it. So there's times that I may elect to not resect a component of it. That's very, very rare. But to sort of go in and be like, this is unresectable, I can't think of a time. Maybe I have a selective memory, but I can't think of a time where I've not, gotten most of it out.
Yeah, I think it's, this is a disease that, a lot of people deal with earlier stage disease, but there's probably just a handful of centers that really deal with the more advanced stage disease routinely. And part of the benefit of that is knowing when you're going to get in trouble and when you're not. So, when you have disease that encases the celiac axis and the SMA, all right, well, how are you going to manage that? You're not going to try to figure that out intraoperatively. You got to have everybody on board, whether it's a cardiothoracic surgeon that can go on cardiopulmonary bypass and then graft those areas. Or, if you've got vertebral body involvement, do you have a neurosurgeon or an orthopedist that does spine surgery to help resect those vertebral bodies? You gotta look at the images ahead of time and really, really make sure you're planning for that ahead of time. And I think if you do that, there's almost never a situation where you're going to get yourself into where you say it's unresectable, and so intraoperative death, I hope not, and, the things that we really worry about in other diseases are, heart attacks, strokes, that are catastrophic, blood clots that propagate from tumor thrombi or even bland thrombus that creates a fatal pulmonary embolism. Those are really the intraoperative things that we get into. Intraoperative bleeding should be pretty uncommon as long as you're following general principles. But these, let's be honest, these are operations where you're totally skeletonizing the major vascular structures of the abdomen, the largest vessels, artery and vein of the body. And so if you're not understanding what trouble you can get yourself into, you can create some serious problems. But if you're experienced, that should rarely, if ever, happen. So I think understanding your limitations in this disease is paramount.
Yeah, I had one case that was about 4 years in. It was a young man that had 2 trips with the pediatric general surgeon that were aborted both times, and extensive disease, suprahilar disease. And I thought I really had planned well for this. Had the CVTS folks actually get intrathoracic aortic control. The imaging was truly offensive. Got both iliacs controlled, and, it became obvious to me after about 4 hours that the likelihood of me getting that out without really hurting this patient was pretty small. That the mesentery, the SMA, it was all encased, and that's the only time I've had to abort. It certainly left a impression on me. And I do mention it, perioperative death. I think just for my bigger operations, cable thrombi, I mention it. I don't try to, bring it up. And my general thing is I'm going to tell you about the common things and the bad things. It all sounds very, very similar. And I'll just say, you should have at least heard it one time from me that you could die, or that I might be able to get it out. And, Rob, one thing that kind of popped up when you're working these masses, it's an aortotomy every 2 or 3 millimeters. It's tough. Frozen sections, do you ever use those? Useless, sampling error? What are your thoughts?
Yeah, that's a good question. So I do not use, I'm trying to think if I've ever obtained a frozen section during an RPLND. I know, there's some centers that frequently use those. To me, it doesn't change my intraoperative decision-making. You're going in with the goal to resect everything, as we mentioned. And so frozen section of necrosis or teratoma or viable germ cell tumor is not going to change the game plan, at least for me. So I have not employed that. I don't know if Tim, you do, or Aditya, you do at your place?
I have not, no. I could see in a circumstance where if let's say you're doing a salvage setting and there's viable cancer and you're worried about a margin, whether you resect a vessel or not, and you've dissected off and you want to check something intraoperatively to see if there's any, cancer, yolk sac or embryonal at that margin. I could see an anecdotal circumstance like that, but routinely, I do not know of a circumstance where that would be routinely helpful.
Yeah, I really don't either. I think some of our colleagues across the pond use them a little bit more liberally, especially as it pertains to possible adjunct procedures. It kind of makes sense, but I think the sampling error is not trivial. So this all, I think, I was just going to mention, these are some of the highest volume centers in the world, and it's just nice to hear that it's a team sport. There's no kind of ego involved. If you feel like a vascular surgeon could bring in something, if they came with a bleeding GI invasive tumor, have a surgeon. It'll probably come off. It does the vast bulk of the time, and thankfully it seems like you don't need a vascular person the majority of the time, but sure, this is one case where I think it's better to ask for permission than forgiveness. That sound about right?
Yeah, for sure. Just to go back to something you had brought up before, one of the things that we do talk a lot about in more advanced cases when you have both abdominal and intrathoracic disease is the risk of spinal ischemia. So, one of the main complications, while it's not death, but being paralyzed from the nipple line down is a big issue. And so if you have a situation where you've got bulky disease and you're going to be taking lumbars on both sides of the aorta, and then you also have retrocrural and posterior mediastinal disease where, those lumbar branches or intercostal branches will be taken, that is a scenario where we do talk about that and have a protocol to try to monitor cerebral spinal pressures and try to do things to reduce those pressures to minimize any impact on perfusion through collateral flow. So that is one thing that I think deserves mentioning.
Yeah, I agree with the latter. Just on the vascular surgery front, Aditya, I totally agree with you. There's a different mindset when you're the primary surgeon calling someone who has no idea. First of all, you don't know who you're going to get on the other end of the phone. Could be someone on call who's never heard of this patient, doesn't know the imaging, versus someone who you've perhaps picked beforehand or communicated with beforehand. They've reviewed the imaging. They may have even met the patient, which is often what we try to do at our place. They've had vascular imaging studies to look at potential vein donor sites, etc. So it's a very different mindset for you as the primary surgeon in a 16-hour battle when you've got someone on the bench, as it were, that you can call in a pinch, and you don't have to start with the 20-minute story. This is a 19-year-old guy. He's had a germ cell tumor. They just like, oh, you need me? I'll be there. And it's a very different mindset for you as the primary surgeon. Forget the actual outcome, but just for you as a surgeon, it's sort of, comfort's not the right word, emboldens you to do what you are set out to do that day. And so I think it's part of that multidisciplinary team concept that you alluded to.
Totally. And I think just like urologic oncologists, there's people that might be more facile with endovascular techniques, open techniques. I feel like we know what we're doing around the great vessels, but you don't want somebody coming in wondering, what business you have. We've all been at our institution for a bit of time. And I think we all kind of agree, it's been touched upon in previous episodes, neck dissections, liver dissections, those would all be arranged, maybe of peripheral VATS. And that's not exactly what we're talking about, but the planning point, I think, is highlighted.
Sure.
All right, so you've reviewed with the patient, you've kind of run through it. What are some of the, I guess, the most common, or maybe the most common, questions that you get?
Yeah,
How about your personal prep kind of leading up to, Rob, you kind of mentioned is this going to be a long day at the office, or you're feeling pretty good about, booking 2 or whatever. Let's just talk about, if you're sitting down with your fellows or your residents and yourself personally, what does that look like?
Yeah, I'm sure it's not rocket science for everybody listening. It's probably very similar to what you do for other cases. So detailed review of the imaging. I pay particular attention to the renal vascular anatomy on both sides, even opposite side of where the main mass is that you're interested in. I look at the ureters, make sure there's not 2 ureters, because we've all encountered that scenario before. Look at the relationship to the vessels. But honestly, other than that, I don't have any fancy ritual or sleep on one side of the bed the night before. It's I think for those of us who, it's not that, for people who do high volume prostatectomies, if you do high volume retroperitoneal node dissections, it's sort of, it's almost another day at the office. Not to say that it's, mundane or easy or anything like that to trivialize it, but it's, I don't lose sleep the night before, and I don't overly sweat it or adopt some ritual. So it's sort of another day at the office.
Yeah. I mean, maybe my 2 cents, and we'll run through some of these vascular anomalies and so forth in detail. I think it's critical to look at the pre-chemo imaging. That's always one thing I'll kind of really try to hammer home, whether you're going to resect stuff that's completely responded, or if a mass shrunk a lot, that doesn't necessarily mean it's going to be a chip shot. Sometimes those can be some of the more offensive cases. So I'll just kick off with that. I think the pre-chemo imaging, again, reviewing the histology, having like a sense of desmoplasia, whether that actually changes anything, no, is debatable. What do you think, Tim?
Yeah, there's a few things I guess I would comment. I mean, I agree with Rob. The vascular anatomy rules the day as far as what you want to pay attention to. Like I did a case earlier this week where on Monday that had a retroaortic renal vein. Not a big issue, but if you're not paying attention and you don't know that, it's going to really distort your superior borders of your RPLND, and it's going to potentially create some significant bleeding, as you're dissecting in the aortic cable space behind the aorta, or vice versa on the periaortic space for that, that left side of renal vein. So you have to kind of understand that and appreciate those subtle nuances. The other thing I guess I would say is, in the more complicated cases, you really need to know what your likelihood of having a vascular problem is. So on a vena cava side, you can look for collateralization of blood vessels, in the pelvis or the abdominal walls that would give you some idea that maybe there's vena caval occlusion. If there is, we'll do, a lot of times we'll do a vena cavagram beforehand, because while you can do MRIs and things like that, it doesn't as well delineate the collateralization of the vena cava caudally to the obstruction to tell you what branches you need to preserve as you're mobilizing. And, if you're going to plan on a caval resection, you need to know where you want to divide it. And then on the aorta side, we were just talking about this today in our tumor board. John Donahue and Rich Foster at our institution would always say, from an aortic side, if there is a distortion of the normal circular appearance of the aorta, you need to be really worried about aortic involvement. And those are the patients you need to be thinking about having vascular involvement to potentially do a graft if you're using vascular for that purpose. So that's what we do. I don't do my own grafts, but those would be the main things. And certainly you have to be cognizant that if there's a risk for a nephrectomy, making sure you understand what the risk to the contralateral renal vascular, like Rob was talking about. But those are the main things. I think paying a real attention to the vascular anatomy is gonna be the most important thing that's gonna keep us out of trouble.
Totally. Yeah. I mean, lower pole renal arteries, you don't want to come across those, especially if you're going to do a nephrectomy for whatever reason on the other side. I think taking advantage of all your reviews, the coronals, the sagittals, you can get a lot of good intel on the relational artery, vein, renal vein anatomy. I always tell the trainees, really pay attention to where that right renal artery is in relation to the left renal vein. Last thing you want to do is you got your intraoperative packet nicely isolated. You're coming in however you come in, and boom, you bang the right renal artery. That's no good. But yeah, I would tend to agree. Large lumbars, obviously there's like a pelvic kidney, things along those. You don't want to get caught with your pants down.
Can I ask a question?
Yeah, of course, please.
Have you guys ever done an RPLND on a horseshoe kidney?
I have not, no.
I'm trying to think. I've certainly done partial nephrectomies. Robotically and open. I don't think I've done an RPLND. Obviously, you have to.
I've done two. It's just really, really interesting anatomy. And you talk about distorted, renal vascular structures, and the gonadal vessels actually course over the top of the kidney and insert into the hilar structures above it. So it creates a very interesting dissection to figure out, because it's hard to delineate retroperitoneal lymphadenopathy or lymphatic tissue from just perirenal fat. So I wind up probably over dissecting and skeletonizing the kidney when I've done it in those two circumstances. But it was kind of an interesting scenario, because I was a little bit at a loss to know what to mobilize. And so you just you're working in between all the branches off the aorta and the venous branches. But I didn't know if anybody had any experience, but it's a challenge for sure. The exposure is not hard, but what you would consider your templated dissection is very difficult. And then trying to follow the neural anatomy, it all kind of courses the same, but it's underneath the kidney. So you have to be really careful below the kidney with what you dissect.
Yeah, I mean, having done partials, the anatomy can be, fascinating. So that'd be cool to see some pictures of that one day. All right, so you studied your film around the time of the operation. It's a day of surgery. Any kind of particular prep? You have teams that are anesthesia teams, circulator scrubs that are doing these cases fairly routinely.
Yeah, no, sorry, I didn't know if you were going to stop there. Yeah, no, we're lucky at our place, and I know you guys are too. People are, it's not like we have a dedicated anesthetist or nurse team, et cetera, but we do it so often that there's experience with it, and there's a general culture of understanding of, okay, this guy's had bleomycin, this guy has a risk for potential major blood loss in terms of what access that they're going to have. So we're lucky. We always do, as I'm sure you do too. You do a detailed timeout with the patient awake in the room before the case, and you discuss all of these things and all these possibilities and the ramifications for the nursing team, anesthesia team, and all of your surgical team members to hear and participate in. And the patient can ask questions too before they go off to sleep.
Tim, anything to add on top of that?
Not really. I think Rob brought up the concept of bleomycin and having your anesthesiologist understand about the risk, and it's with 4 cycles of bleomycin that the risk goes up, not with 3. So, but if they've had that 4th cycle of bleomycin, making sure preoperatively you're getting pulmonary function tests to make sure that they fully recovered, make sure that they've got good lung expansion on physical exam, and make sure they're not symptomatic at the time. If not, wait on those patients. I promise you will be glad you did. There's no rush in somebody who's struggling from bleomycin toxicity, because the worst thing you can have is somebody starts spiraling with progressive pulmonary fibrosis. It's the worst thing you've ever seen, I promise. But I think, from an anesthesia standpoint, I'd be curious to know how everybody manages perioperative pain. But, right now our anesthesiologists are running a prospective study looking at a couple of different pathways, either through intrathecal injections versus tap catheters for postoperative pain control. We never use epidurals just because patients usually aren't in the hospital long enough to benefit from them. But, mostly with oxygen supplementation and the fluid volume with patients with bleomycin is an important thing.
Yeah, we use intrathecal morphine. Also, don't really use epidurals. They're generally not required. Rob, anything on top of that? Anything kind of specific, RPLND, ERAS-wise, minimize narcotics, get them some Tylenol and some type of NSAID before the operation?
I don't think I have anything specific to add. I mean, today we're talking about post-chemo RPLND, so generally they're in the hospital longer than primary. So we do still use epidurals, I would say maybe half the time if I had to estimate. I let anesthesia drive that discussion, to be honest, and it's a conversation between them and the patient. I find not too huge a difference whether it's patient control analgesia versus epidural. That's just personally, anecdotally. I know that goes against what a lot of the evidence suggests in terms of enhanced recovery after surgery. But yeah, nothing specific to add on top of what you've already said.
Okay, and despite having your teams, let's just say you transfer to a new hospital, and you're running through things with your nurse and your scrub, what are going to be like the 10 things that you're going to be doubly, triply sure are on the table and available before you start?
I've never been asked that question. That's a good one. 10 things? Well, I don't know. Let's see, Tim.
What about five? Five and then
yeah.
extended criteria.
Paired bakies and Mets. Sorry, Tim, you go ahead.
I was going to say, you just got to put a Penfield on there, right? Just to throw a...
Yeah.
Penfield's got to be on there.
We'll use that. Yeah. I do, I would say 95% of the work for me is cautery or Mets. Those are the things that are in my right hand is cautery. I dropped the cautery down to 20. And I know this is very different than where the three of us did our fellowships in Memorial Sloan Kettering, but I use a lot of cautery, what we call electric dissection in Toronto. I learned it from Dr. Michael Jewett during my time here as a resident in Toronto. And so I use a lot of electric dissection with cautery at 20. And when I'm not doing that, it's Mets in the right hand. So I'm not a big sort of Lauer person. So it's occasional Penfield, but otherwise Mets and cautery. And that gets me 95% of the operation done.
Yeah, I mean, for retractor, we use Bookwalter for exposure, and that works pretty well. I actually do a fair amount of dissection with electrocautery, just like Rob has talked about. There was a gentleman by the name of Ken Kessler, who was a thoracic surgeon, that I kind of adopted a lot of his technique, working with him early in my career. Other than that, I mean, I can't think of anything in particular.
I mean, I know, Aditya, different forums, we've talked about energy devices, and I know there's a great variability across people who do RPLNDs. And lately I have embraced ligature, which I didn't used to. I just used to put, a million clips. I'm being sarcastic, but like a lot of clips to control lymphatics. And then I sort of went away from that towards ligature in hopes of reducing a rate of ascites. I feel, at least anecdotally, that it has reduced the rate. But it's interesting in talking to colleagues, I find half of our colleagues have sort of gone the other way, where they say, I've gone away from ligature because I had chylous ascites, and I put a million clips. And so it just shows you, I think there is no one right answer. So I don't know, Tim and Aditya, if you use energy devices in your RPLNDs.
If I may, plenty of Bovie. And I think, honestly, reflecting on it, I think some of that's probably comfort and familiarity with robotic surgery, where you're used to developing planes and allowing them to declare themselves without the use of a right angle. It's just different. Yeah, I do use a ligature. I mean, if I was stranded on an island and had to do big nephrectomies or RPLNDs, it'd probably be a pediatric yank hour, a ligature, and a bookie, which I would really like to have. Maybe a couple of get out of jail sutures. But yeah, I do use the ligature. The residents will ask me, the fellows will ask me, how do you decide for a lumbar if we're going to use a ligature or clip it or tie it or do whatever? And there's no like rocket science to it. If I feel like it's easily accessible, like God forbid I was to, it was to bleed after dividing with a ligature, I'll use a ligature. For like a primary, I use a ligature almost all the time for the lumbars. If it's a situation where the cava or the aorta is really kind of stuck and glued in, where a misfire or a partial transection, something could really change the tone of the operation, I want to have it controlled and get a tie and, whatever I think is required, at least on the great vessel side. The specimen side, if you will, seems to be a bit more forgiving, generally speaking. But yeah, nothing beyond, I think, what you guys are describing.
Yeah, I guess my comment would be a couple of things. One, we have a end-seal device, which is similar to the ligature that we've been using. We're getting ready to switch back to ligature, but I use that in some circumstances, just if in a circumstance where I've not nerve spared, and I'm just taking the stuff off the posterior body wall to divide the lumbars. I'll use it along the posterior body wall principally. That's probably the only place that I use an energy device. Outside of, electrocautery dissection, I use like a Penfield just to pay homage to Joel Scheinfeld, but I find that very helpful in very desmoplastic dissections along the aorta and the vena cava. It's a little bit more delicate than a right angle and certainly more delicate than a Bovie to work through that plane, and it works remarkably well for me. But a number one Penfield works really well in that circumstance. And so I guess those would be the few things that I would contribute to the conversation.
It's always good to hear. I saw Sia doing some cases, and he uses Mayos. He likes the bluntness of Mayos over Mets. The group from Tots at Memorial, they describe their belly up technique with the back of a 15 blade. We're all at a Memorial. And I guess the bottom line is there's probably no right answer. You should probably have some tools in your toolkit, and if it doesn't work out with your safer, blunter instruments, then you kind of kick up the chain until, you may be sharply dissecting it off. One other tool that it's kind of nice, I wouldn't say it's mandatory, it makes things a little bit easier, that I've borrowed from our liver colleagues, is an aqua mantis. Sometimes for retracted lumbars or slightly frustrating ooze, I think it's a good tool. Not like a game changer, but I don't know. If I had an extra $500, I'd probably put it on the kit and go with it.
Just to go back, I did a case, a reoperative case on Monday, and I used a scalpel. I had a very densely adherent tumor to the aorta, right at the bifurcation. I'd be able to mobilize it off the bifurcation of the cava. So it was essentially just that medial border stuck to the bifurcation right at there. And I just used a scalpel to kind of work through it, and then allowed me to kind of sharply dissect what was felt to be active cancer off of there and kind of working through that plane. You got to be careful with it. You don't want to cut into the aorta and create a problem, and we can talk about vascular control and with difficult masses as a subsequent conversation. But, that's another way, because sometimes, if you're using a pin field, that's a blunt dissection. If you're using a bovie, if you're using a back end of a scalpel, if you're using right angle, whatever you're using, sometimes those aren't delicate enough or precise enough, and a scalpel sometimes works really well if you have kind of two ends of a mass localized and you just got to connect them. Sometimes I'll just work through that with a scalpel, and it works pretty well.
I think it's rare that there's no plane along the great vessels, and there may be a small portion where there is no plane, but 90% of the rest of the surface area there actually is a plane. And so it's that sort of sharp dissection, Tim, you alluded to kind of get into that plane, and that plane may be a nanometer wide, but once you're there, then you can utilize the more blunt dissection, whether that's Penfield, Metz, back of a 15 blade, whatever the case may be. But I think it's rare that there's no plane.
Totally agree. It's like a prostate, right? That nerve-sparing plane exists somewhere. You just got to take your time, be patient, and find it. Okay, so positioning, supine, slightly flexed for a garden variety case, does it sound about right?
Yeah, I used to flex like in my second year. I don't flex anymore. I just keep them supine.
Okay.
Just to comment on that, I think this is something I talk a lot with the residents about, and the fact that if you flex them, you create more tension on the rectus muscles. And when you're trying to, especially if you're trying to minimize the size of your incision, you have to move that incision around to the right upper quadrant, right lower, left upper, left lower. You need to move that around, but the more flexed you have them, the tighter the rectus muscles are, and the harder you retract on them. In my experience, the more muscular spasms that they have and the more trauma you have to the abdominal wall. So you actually are going to get better retraction if you do not flex them. So there's some circumstances when you have a really obese patient, they have a huge kind of abdominal domain and a pannus, that you flexing them actually helps you, but that's the rare circumstance. I actually do not flex either.
Okay, and one thing, just jumping back to the scalpel conversation, we all had the benefit and privilege of training under Dr. Scheinfeld, and I can still recall him saying, a cut vessel is a little bit easier to deal with than a torn vessel, and no matter how blunt the instrument is, you can make a hole in it, and a torn scenario can be more challenging to manage than not. All right, so Clinton, you mentioned incisions. Let's hear it. Typical garden variety, not super crazy. Maybe if it's like extensive suprahilar, you can consider a chevron. Otherwise, limited midline.
Pretty much midline for everything. We, John Donahue, Rich Foster, Joel Scheinfeld, they all work through a midline for the most part. It's pretty rare to need something beyond that. If you're looking at more early stage disease, I think we've progressively tried to minimize the impact of the incision, especially on left-sided tumors, because you can mobilize the colon and really limit what you have to do to expose that. And so usually it's about a hand breath for me, right at the beginning at the belly button cephalad. I always tell the residents that you have to pay attention to the location of the belly button, because it's not necessarily the same in every person. So the distance between the belly button and the xiphoid and the belly button and the pubis can be quite varied, even though anatomically it should be relatively consistent. But Some patients give you a really, really long distance, and you always have to think where you got to get to relative to the orchiectomy site, right? If it's a testicular primary, if it's a retroperitoneal primary and you're not worried about resecting the gonadals, then it's not as much of an issue. But 99% of cases that we're doing, I'm always thinking about that distance between the caudal aspect of my incision and where I need to be able to retract down to get down to that internal ring to retrieve the entirety of my spermatic cord. So it does vary a little bit. It's pretty rare for me to go in for umbilical with my incision generally, but obviously if you have in more advanced cases, let's say you got a 30 centimeter mass, well, then you're doing kind of stem to stern kind of incisions, but those are pretty rare for us these days.
Tim, it's like you're in my brain. Like on my notes here, I have like a favorable xiphoid to umbilicus distance. That's kind of nice. It's all like right there. I always talk about, in the lower edge of your incision, the retraction can be a little bit less. So you almost more have like a trapezoid than you do like a pure rectangle, because a lot of the work is done at the upper elements of the incision. If you're doing concomitant pelvic disease, I think you just kind of need an incision to be able to accomplish the goal. And sometimes it is, a exercise in masochism to have this nice small incision to do the RPLND, and then it's just brutal getting out the cord. And I guess, what an extension would be if they were a patient that had a biopsy, got chemo, testicles in place. Are you trying to manage this through the same incision, or just make a counter incision and get on with it?
Yeah, I think it depends on the size of the primary, right? So if it's a small residual mass following chemotherapy, because in the primary setting, every single person outside of a retroperitoneal primary tumor, but even that circumstance, they've had chemotherapy probably. But if you're doing an orchiectomy in a delayed fashion post chemotherapy, I'd say almost universally, with a few exceptions, I do it through the same incision. So you can usually mobilize the testicle up through the canal, up through the internal ring, and divide it. I've never tried to place a prosthetic, although I guess you technically could, but it's a high risk operation at that situation because of the amount of ascites that will kind of work their way down into that space. But yeah, I've always been able to do the en bloc orchiectomy through the same intra-abdominal incision for a reasonably sized mass.
Rob, what do you think? Does this all sound about right?
Yeah, I would say to me, usually post chemo, the testicular masses are pretty small if you haven't done the orchiectomy. So, I don't do it through one incision. I'll make a very tiny, inguinal incision, and usually by the time the other team members have the abdomen open, I've got the testicle all up and ready to go, and just transect the cord, and then it just pulls up through the abdominal incision. So I've not done it all through the abdomen. I think the morbidity of the inguinal incision is not that much. The rest of the discussion, it sounds like, at least based on your description, I make a bit bigger incision than you guys do, but that's, again, at Toronto, we've always routinely done bilaterals. Whereas I know, depending on the case, obviously in the post-chemo setting in Indiana, you do, modified unilateral. So maybe that allows you to get away with slightly smaller incision, but otherwise everything you described all the principles are very similar to our approach.
Yeah, I think to kind of piggyback that on two things. One, when you talk about the incision, make the incision the size. My fellows and residents, they wish I made a bigger incision, right? Because it would be easier for them. It's hard to get exposure, so you kind of have to pick and choose your battles. But if it's more comfortable for the person who's doing the operation to do a bigger incision, then doing a bigger incision, right? Be safe. You don't want to put the patient at risk in any way, shape, or form by limiting that. The one thing I would say is that if you do the orchiectomy through the abdominal incision, you create this communication with the intra-abdominal space, with the scrotal space, and I drain all of those. If you do not, you will get this, with gravity, this huge transmission of fluid in the scrotum, and they'll blow up like a water balloon, and it's miserable for the patients. So, and I don't know, one of the things that I try to avoid with that counter incision is that sometimes you can have concerns of wound dehiscence with that amount of fluid that will work down there. So we use scrotal supports and intra-abdominal drains to minimize that fluid transmission. So Rob, I don't know if you do anything different with the way you do yours with a second incision or counter incision.
Yeah, so you're right. That's a risk. I can't think of a case where I've had sort of a almost like a hydrocele secondary to your ascites. Interestingly, I get that robotically, from time to time, but I have not had that in the open where I've made a small incision to get again, we're only talking about that rare situation where you haven't done the orchiectomy before your chemo and you're doing the orc at the same time as your RPLND. I don't sort of routinely drain those cases where I've made a counter incision and go after the testicle. I would say in post-chemo RPLND, I may leave a drain 10 to 15% of time. So it's a rare time that I do it anyway. And I can't say that I particularly do it in those cases, but your rationale is very sound.
No, it makes sense. Now, Tim, I was kind of relieved to hear that you guys use a book Walter, because I kind of felt like I was getting a little bit outdated since, I've used the Thompson and the Omni, and those seem to be very popular with our surgical oncology colleagues as well as our transplant folks. Rob, are you still using a Gallagher hooks and chains, or what do you? That was a joke.
Okay, I didn't know. No, I do not. But
I think there's one set that still exists, and I'm pretty sure I know where it is.
You know where it is. Yeah, 68 New York. I use an Omni for 90%, let's say, and then if I find the Thompson, particularly if you have to do upper quadrant work. So if you've got retrocrural masses, or if you're going to have to do a concomitant liver resection, then I break out the Thompson for those cases. But 90%, I do it with the Omni/Wishbone, and that gets the job done.
Yeah, I think this is, again, going to be whatever you're comfortable with, familiar with. I personally think with the bookie, having the ability to fix the retraction and less malleables is something I appreciate, but I've seen tremendous surgeons, really get wonderful exposure, and I don't think it's a major point one way or the other. All right, so I think we've gotten to making an incision. One quick question: extraperitoneal, are you guys doing that? Have you had much success or experience, or just feel like you got a good thing going? Kind of know what that looks like in your hands? And
so I have not. I've had years of conversation with Dr. Danishmand about trying to get down and spend some quality time with him and learn the way that he has published on it and his videos that he has on it. And he's graduated, people from his program who have gone on to do it. So that's the only reason I have not, is because I want to spend time with him before I embark on it. So I still, everything is trans, whether it's robotic or open. It's all transperitoneal for me.
So, we've kind of heard Sia's data over the past several years, and he updates it, and he touts reasonable advantages to it. I've done it on a handful of occasions. We're actually setting up a prospective trial that we've discussed with Sia to randomize patients between transperitoneal versus extraperitoneal, to kind of see what the real advantage is in a kind of a high volume center. So hopefully we can get enough patients randomized in that context to be able to get reasonable data over the next couple of years. It'll take us a few years to enroll the numbers that are needed to power the study, but hopefully we'll learn more about it. But I've done it a handful of times. It does pose some challenges. I think that when you talk about going and seeing and working with Sia to see how it's done is probably a pretty reasonable thing, because it's not necessarily the same as a transperitoneal approach. You have to really, I found that finding the gonadal down low and then working my way up seems to help me quite a bit, because otherwise that plane up high between the kidney and the colon and releasing that plane down can be somewhat difficult to find in some patients. So that's been my preliminary experience on a handful of patients, but we'll see.
Yeah, I actually got to go there as kind of in conjunction with the Shelby Webster, saw him do a case, and it was adequate to be able to do it on a very favorable case, primary and so forth. When I extended it a bit outside of very favorable cases, it worked. It's kind of weird when you feel like you've got your methodology for approaching an operation fairly well controlled, and then to change that substantially. Not that, I'm a total old dog that can't learn a new trick, but on the left-hand side, you're like, oh my God, am I about to get into the Dewey and just have no idea? I think the right side is a little bit more amenable. The cava, the Dewey tend to come off on the left side post-chemo. Sometimes that sigmoid mesentery and the retroperitoneum are a bit more adherent. And I just want to make sure I'm not getting into something I don't want to get into.
Be sure to tune into our next episode to hear the rest of this conversation.
Thank you so much for listening. If you haven't already, make sure to follow, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, you can direct message us at _BackTable Euro on Instagram, X, or LinkedIn.
BackTable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.